Okay, so after such fantastic morning session, I would come to something simple. But when simple things go wrong, it's very frustrating. You think, I know it, I do it every day. And then it doesn't go wrong, it doesn't go well, very, very frustrating. So this was one such occasion, and I thought I'll present this case. It's a common injury, and it is commonly maltreated. I happen to be fortunate learning from others' mistakes in these cases because I hardly get fresh injuries to treat. But when I see old injuries, these are the ones that I get. And that was the reason I thought I'll share this. Residual function can be very disabling. A lot of injuries patients want to live with it. हड्डी टूटी थी, चल रहे हैं, thank you very much, बहुत बढ़िया चल रहा है, सब चल रहा है. But there are injuries they cannot live with. And this is one that injury, commonly maltreated, and patient cannot live with it. And he has to undergo second surgery. Assessment and treatment is very difficult for a secondary surgeon like me. What to do? Patient is full of all negative things. उसने ऐसा कर दिया, उसने वैसा कर दिया, मैं ठीक नहीं हुआ. Now this patient is minus everything with you, and he is expecting you to do something that will work. So very difficult to plan such a patient. Some new techniques have brought some hope, so I thought I'll share that also with you. So this is a 30-year-old young doctor, lady doctor, sustained injury 10 months before she saw me. This was a very common kind of a fracture. Her classmate, an orthopedic surgeon in the same hospital, obviously you go to him and he treated her. And this was done very nicely, CT, of course MRI was also done, which I don't do. And I'm sure everybody will fix it. Till now, there's no controversy. So this is what was done. Now this is where the whole problem is. This is simple looking fracture, medial condyle, type 4 is the one which is very nasty when it comes to fixing. So one point, even undisplaced fracture of medial condyle type 4 needs to be fixed, not plastered. Number 2, when you fix them, be very sure that you've got 100% reduction. It looks quite good on a image intensifier because it shows only this much. I have this practice of keeping a normal X-ray of the patient next to the image intensifier. That's where I want the medial condyle to go. This is of course where, I mean, it has gone very, very far away, but I'm sure sometimes it is difficult to get that medial condyle lifted properly. So this is what was done, and that's how she was walking to me 10 months after surgery, very upset, because she can't walk fast, and she was unstable. And I have taken her permission. Can I present your pictures? I will hide your identity. She said, I don't mind. So she was Ginu Welcome, as you can see on that side, and I asked her to stand on the normal side. She could.
Now stand on your left leg.
On the normal side, she could not stand. Very unstable. So her problem was instability. So after a fracture, patients don't want to come to the doctor unless they are unstable. They cannot trust their knee. And that is the situation here it was, and that is how she was standing. So that's how she came to me. This where the first ARS question is. Inadequate assessment, inadequate reduction, inadequate fixation. Everything was wrong or something else in your mind. So, 4 number more than 1, okay, right. So I think, yes, to assess them, he has done a great job. He did a MRI, everything. And reduction was not good, which is all right, 34% say. And fixation was reasonable. I agree with whatever everybody has said, and a lot of things could have been better. So essential thing is to get the right reduction on the table. When you think it is good enough, it is not good enough for medial condyle tibia. So I've done quite a few of these cases which look very good if you look them casually, but that patient is unstable. And they're all referred to me for ACL reconstruction. That's another very interesting thing. Very well fixed. Initial surgeon says, very good job done. Iska MRI kara lo because it's instability ho rahi hai. MRI always shows ACL tear. Now refer to Dr. Maheshwari for ACL reconstruction. But this is what we call bony instability. It's not ligament instability. So we proceed, and this classification is not much talked about, but very often you have these tricky fractures If they fall into one of these fracture types, these are waiting to be unstable fractures. So better be very careful about fixing and looking for these fractures, and apart from Schatzker classification, these are all very unstable fractures. If you don't fix them well, you'll end up with instability. So we did further workup. Of course, MRI was done by the patient herself. I do a CT, and I definitely must have done a CT. I don't have the images now. And we do a standing X-ray to see what's happening. It's an alignment problem. Medial condyle is gone. On weight bearing both sides, as you can see, it is more into varus, but always in a single limb injury, single leg weight bearing X-ray is very important. And here it shows, it is actually going to valgus. That's very interesting. Normally when you have a medial condyle depressed fracture, it should be varus. Now this lady is in valgus. And if you remember the way she was walking, she had a valgoid gait. It was not a varus gait. Now that makes me confused. What am I going to do? If I correct this deformity, it is already valgus loading. Am I going to make it more valgus? What do I do? So there was a little bit of a confusion in my mind what to do. And I did a stress view to see why she's unstable in a coronal plane. Because mediolaterally something is lax. Expectedly, because medial condyle was depressed, so it was expected that there is going to be a depression in the medial side, so that is the reason for instability. So we know some corrective surgery has to be done, but I was wondering what to do because she has a valgus on loading here already. So that's where my second ARS. She is medial condyle malunion, and what will you do? So most people will redo the fracture and correct the malunion. 20% other. Can I ask who is the other group? What else? Yes, please. Let's have discussion.
So I think I'd like to look at the MRI as well. And this is a problem of depression and angulation of the medial fragment. So an osteotomy, in the sense, a complete high tibial osteotomy is not going to work because the alignment is fine. You need to do something like similar to a TCVO, where you have an intercondylar osteotomy to elevate and angulate it back again, and then fix it or maybe bone graft it in the opening of the wedge.
Okay.
So in addition to that, if there's any ligamentous abnormality, you need to tackle that as well.
Somebody other? Okay.
Was that a pseudo ligament laxity or a true ligament laxity on stress view? You showed the stress view, no?
So I'm sorry. How do you define that? How do you find out?
So do you feel that the medial joint opening was because of depressed medial condyle, or it is a MCL injury as well?
What do you think was it on the X-ray that I've shown?
It is
I thought it was depressed medial condyle.
Could it be associated MCL injury, or with the surgeon who operated inadvertently damaged the MCL?
Oh, okay. That's a good thought. I never thought about that. I thought it's a varus injury. MCL will be protected, and because it is
MCL will be
malunited,
protected, but the surgeon while operating.
Maybe the surgeon can do it. I may accept that. Yeah.
The very fact that it is going into valgus in a medially depressed fracture. So the first thing that came to our mind, we were also discussing, it's the MCL injury. So I pressed D, other, because it will need bony as well as probably a ligament reconstruction also. So that's what my thoughts are.
So very important point.
And we need a comparison view for both the knees to find the difference in that case.
So very important point, though she had a medial condyle depressed fracture, why was she walking in a valgus gait? That is something very important. Anybody wants to comment on this?
So what was her LDFA?
Sorry?
Her distal femur looked quite in valgus.
Everything was normal. Oh, she is a valgoid knee. On the normal side you could see. So basically I was thinking why she was walking in valgus, though there is a medial. I have seen a lot of medial condyle malunions and they walk like this, they are in varus. She was walking in valgus because basically she had a valgoid knee to start with, and to balance her unstable knee, that was the only way she could walk. Her knee was valgoid to start with, could have not gone that much varus to produce a varus gait. That was my interpretation in my own way. So I agree that of course most people will redo, and that's what I have been doing for many years, but this time I did something different. Sorry. So this is where the situation is, and we have an option of doing STO and TCVO, and I was wondering, can I do STO? But as you know, already valgus, 1 degree. And if I do STO, what am I going to do? What for? She's already valgus, walking valgus. What STO am I? So STO is completely out in this case. A lot of time, all kind of upper tibial malunion, we have this fixed solution of STO. So that was completely out. And TCVO was one option. Why should I do TCVO? In the past, I have always redone the osteotomy, like opened up the fracture again. But this fracture was just too small. It was very, very high medial condyle fracture. So I had to do some kind of a osteotomy lower down. In the past, I have done an oblique intra-articular osteotomy, which is described in the books, and have treated them very well, and they did very well as well. And this time I decided to do TCVO because this deformity, what is teeter deformity of upper tibia, fits into the indication of TCVO. TCVO is actually described for osteoarthritis, but osteoarthritis where medial condyle is depressed and there is instability inside the knee, you do TCVO even in osteoarthritis there. And here you have a similar situation. The situation is medial condyle is depressed, teeter effect is there. Why not do TCVO here? So I decided to do TCVO, and main problem here was instability and not pain. Unlike osteoarthritis where TCVO is described, but teeter effect was here. With the stress view, we could see that it was an intra-articular deformity needing intra-articular correction. So between redoing and TCVO, I chose TCVO, and I was thinking, why not? I have done redoing of the fracture earlier, and that has worked as well. But because in this case, the fragment was very small, number one. And another thing is, when you do a redoing of osteotomy, you create an open wedge, and you have to put a graft there to support it with a plate there. So I thought TCVO gives me a better exposure. So challenges, the surgery was done from the medial incision. That's not the incision I would have used for osteotomy now. So I have to have a parallel incision next to it. Obviously, there can be an issue of skin necrosis, so I had to plan my incision. I made 2 small incisions to remove the plate and not a big incision there, and then very carefully measured some 5-6 centimeter distance and made a rather oblique kind of incision to get to my bone. And we did a TCVO, standard way, vertical and the horizontal cut, and that's how it happens. You make a vertical cut, medial to the patellar tendon, and a horizontal cut, and open it up, and then fix it with a plate. No grafting. So TCVO, you don't need a bone graft. And obviously you can't open it hugely, but whatever TCVO is required, and whatever I have done till today, you don't need bone graft. Such a spongy area, huge area of cancellous bone, and just a good plate is good enough. You don't have to put the screws all the way here, because I was so much biased with my STO techniques, but you don't have to put screws so long. So you don't run the risk of going at the back of the knee, screw penetrating and causing vessel damage. So no use of graft, number one. Not using long screws, number two, is an advantage over STO, generally speaking. But here, because between redoing the fracture versus doing a TCVO, I could avoid using the bone graft. That was my reason for doing TCVO. This is what finally it looked, and then it healed up like this. It looks quite okay. And then this is I think 3 or 4 months after surgery, and she was happy. She was walking very well. She gained her confidence. Lymph was still valgus. So what key message is, it is not STO always. So don't do STO everywhere, wherever you have a unstable knee with malunion. So she was quite happy walking, and the leg was almost same shape as the other leg, which was also valgus leg.
Ujjwala, after surgery, how much better do you feel on a scale of 0 to 10?
8 to 9%.
80-90% you're all right?
Yes.
Chalo, that's a good.
So I wasn't myself sure whether the surgery I have done, she will actually feel better. So I took this opportunity to ask her very sheepishly, and she said 80 to 90% better, which means the plan was okay. So now, I have earlier done such cases like this, as you would agree, you all have done it, and they've done equally well. And TCVO is a new concept, and it has come actually for osteoarthritis of the knee. But first time it was described in 1989. It's not something new, but since it came from Japan, it's not very popular. They do it for all grades of osteoarthritis. And the philosophy is very different compared to STO. STO philosophy is you shift the line of weight bearing laterally. That's not what TCVO is. You just make the joint stable. Their concept is when the medial condyle depresses, even if you do STO, this is what keeps happening inside, and that knee remains painful. So you rather lift the medial condyle by TCVO, it makes the knee stable, and that takes away the pain. It may not correct the deformity. The line of weight bearing may not go to the lateral compartment, but still it works, and they have shown nice follow-up for many, many years. So if we compare STO with TCVO, the goal is to shift weight bearing. There the goal is to achieve intra-articular stability. They don't care about where the weight bearing is going. It is indicated, STO is indicated in cases of primary high tibial where MPTA has to be corrected. Whereas where JCLA is a problem or there is a teeter effect, STO will not work because it will still remain unstable. Complications of STO, hinge fracture, TTO fracture, especially when we do, geometric osteotomy is there. No such complication with TCVO. Screw length, you don't have to be particular. In STO, when you are doing, you're always worried one of the screw may actually go at the back of the knee and may cause vascular damage. That's not required because you need very short screws. And then weight bearing is almost immediate because lateral condyle is all solid. Medial condyle you are fixed with a plate. Though I have not done full weight bearing on day one, but within 2-3 weeks you can start full weight bearing because the lateral condyle is all very, very solid. So I think overall there are indications for TCVO. Overall in general, this was very classical TCVO indication in a trauma situation. So I thought I will just present it here. Thank you very much.
Wonderful presentation, sir. Any questions?
In this case,
yeah, please.
is it important to look the cartilage and the meniscus in that area or do something for that in this surgery itself or?
Yes, so MRI was there here in this case, so meniscus was normal. Normally I would do a diagnostic arthroscopy also before and as a matter of principle, before I do any reconstructive surgery, second time, I scope the knee. Just because it's in my hand. Very often I have had surprises. For example, once I took the patient for reconstruction and when I scoped it, there was no cartilage on the femur. So I actually had to abandon the surgery and patient was about 55, 56. I told him you need knee replacement. I'm not going to do anything. So I think when we have arthroscope with us and if we are doubtful, it's a good idea to scope it and be and then you can explain to the patient later if there are some residual symptoms. In this case, I didn't do it.
I think, sir, I would have done a similar thing, sir, here. That's why I have take other, because I would have done the TCU. I have done around 3 cases and with 1 year follow-up. Even if this patient would have not in valgus, still TCU would have been a better choice because HTO will further deteriorate such situations. So any cases where there is a incongruity, tibial subluxation, or it's kind of a pagoda tibia which is there, so I think TCU is the best option. HTO would be kind of a contraindication in such cases.
True. So there is no doubt STO is contraindication in a case like this. One message, because a lot of people do STO for everything.
Did you get a scanogram of the patient post TCVO? Because TCVO also causes valgization of the knee.
I don't think I've done a scanogram. Okay. I will do it. But from the clinical look of it, it looks like identical both sides.
So you never put bone grafts in any of your TCVOs, sir, here?
No.
No bone grafts?
I've done about 7 or 8 till now. I don't put bone graft.
So from the technical point of view, your the osteotomy that's going intra-articular, I found in both the cases you've gone lateral to the tibial spine.
No, it's medial. It's medial, just medial to the patellar tendon, somewhere in the intercondylar eminence, you can say.
Okay, it looked
it's
like
that. It's not lateral.
Thank you, sir, for presentation. I would like to ask about, did you suspect that the cause was iatrogenic? I agree with the previous opinion that MCL was iatrogenic injury by the previous operation of the plating. Do you agree with me of that? And you have said that the valgus after your operation is still present. So do you have a stress valgus X-ray after operation of the last operation?
No, I didn't do it. I mean, I got so pleased with her
What's the
80-90% result.
Okay.
But maybe I'll call her and do all this
Okay,
just to complete.
she's happy, but do you, what's your opinion about if we do MCL reconstruction instead of osteotomy, what you have done? Do you agree about
So are you saying you would do MCL reconstruction instead of osteotomy?
Is it their role for this?
No, not at all. This is a bony pathology, bone malformation. Even if there is a MCL injury here, first I will correct the bony pathology, check again, and maybe there I can add MCL reconstruction if it is unstable.
Thank you.